Welcome everyone to this meeting of the Health Overview and Scrutiny Committee. This is the meeting at County Hall. It's currently 2 o'clock on Wednesday the 5th of March, and I'd like to welcome everyone here. This meeting is being broadcast live to the public via YouTube and will be available viewing on the YouTube channel after the meeting. Please, as usual, the microphones are sort of linked to the cameras, so please make sure that you only press the button to speak when you're ready to actually start speaking, and please make sure that the button's pressed and the red light goes off as soon as you're finished, and that way the cameras can then operate on the next person that is speaking. We are not expecting a fire alarm, but if the alarm does go off, please exit the committee rooms via the door you came in, turn right, go through the double doors, down the stairs, and then that leads out to the fire exits. So I welcome Nick Chapman to this committee as one of our new members. Or new to this committee rather than actually being a new member, but new to this committee. So welcome to you, Nick. Also welcome the Cabinet Lead, Louise Richardson, to the meeting, and also Mr. Champion as well. So welcome to all of you. So we're going to start the meeting just going through the usual bits and pieces of item 1, which is the minutes of the meeting, which was held on the 15th of January 2025. Is everyone happy to accept those minutes? And yep, excellent. Okay, thank you very much. And on to item 2, question time. We haven't received any questions from the public. Likewise, item 3, which questions asked by members under Standing Order 7375. Haven't received any questions from members. Item 4, to advise of any other items which Chair has decided to take as urgent. There are no other items. Item 5, declarations of interest in respect of items on the agenda. Betty? Generic one. Okay, absolutely. Thank you very much. Any others that anyone wishes to make? Brenda, likewise, generic one. Okay. Anyone else? Ross, likewise. You probably are. There are only trained medic in the room, so if there are any emergencies, as long as they're teeth related, then you're okay. Okay, good. Okay. Item 6, declarations of party whip in accordance with overview and scrutiny. Rule 16. I'm assuming there are no party whip items. No, there aren't. So on to item 7, presentation of petitions. Under Standing Order 36, there are no petitions. So, right, we're on to items 8, 9, and 10, which are the 3 papers that are with us today. As usual, we'll take all papers as read. So thank you very much. We have quite a few papers in PowerPoint format, but we've had a chance to read through all of those. So we will take all papers as read, but what we will do is take any opening remarks from each of the presenters in relation to any of the sort of key items that they wish to draw our attention to in the paper at the start of each of the items, and then we'll go straight into questions and any points that any members wish to make. So item 8, which is understanding NHS patient insights. So this general item is going to be jointly presented between representatives of ICB, UHL, LPT, and Healthwatch. And as a result, we have a fair number of people joining us. Welcome to everyone. So we've got who we've got Fiona, who's actually one of our members, but also part of Healthwatch, so we'll be able to help on that. We've also got Hardup as well. No, not just you. Okay, that's fine. I was going to say I didn't spot her in the room, so that's fine. And then also we've got Jenny Goodwin here. So Jenny, good to see you. Alison Kirk, good to see you. And also, Sue Burton as well. And also Neelesh as well, who's joining us. Are you for this item as well? Next paper, in which case you stay there for the next paper. I won't expect you to come leave the table or come back, so that's fine. Right. So who wants to start with a few comments, opening remarks about the sort of context of the paper, and then we'll start with the general discussion and everything else. Is that you, Jenny, by any chance? Okay.
Good afternoon, everybody. I will do, as you've said, just give a bit of an overview of what the purpose was. So we were asked to share with you all some information and some insight into how we gather feedback into our system. we took it upon ourselves to come together to do that. So ourselves, the ICB, LPT, UHL, so Leicester Partnership Trust, University Hospitals Leicester, and Healthwatch, who also contribute massively into that space, to just pull some, I would say, some oversight into how we gather insights into what our population have to tell us in regards to the services we provide. So what we shared with you is an overview in regards to how we gather it, what we do with it, and hopefully some of the ways in which we use that to inform the service change or the service improvements to ensure the fact that we continue to deliver the top quality services we do across the organisations. Specifically from an ICB perspective, and I know you will have looked at this, there are some heavy slides, but hopefully they were helpful, just to share an overview of how we do use a lot of those general insights that we do come to you on a regular basis to share. So that covers off things such as the consultations, and one of the big ones perhaps we're all aware of is the GP survey, where we did that last year and we're about to embark upon that again, which was approximately 29,000 plus people that informed of us their views on services, and then how that then gets fed into our decision making and our processes in regards to improving services. So it was just to sort of highlight how we use that. I'm sure you probably have got some questions, or if you want to ask afterwards, we can certainly flush that out as well. And then also supporting that is the fact that we have something called, which we're still building on, but have got a great foundation, which is our Insights Hub. And that's something, again, that all partners, including Healthwatch and the voluntary sector, contribute to massively, and something that we really see benefit of for the entirety of Leicester, Leicestershire and Rutland, because what that aims to do is bring together all this rich information that we hold across all the organisations telling us what people think of our services, essentially. And this hub provides us with a place of not having to repeatedly go out to the population asking them the same questions. And that's something that across our system we really want to think about how we make that as valuable as possible. And it's something certainly our team in the ICB is looking to do in supporting that space. So that's that. I've obviously, the team have obviously referenced some of the key sort of areas of which we use the insights, and some people will be aware of this, others perhaps not. So we have something called the Public and Patient Involvement Assurance Group, which is another place in which we use to scrutinise and make sure that we gather insights from our population. And that's something that, as part of our current workload, we're reviewing to make sure that is as robust as possible, and we'll come back to that. So that gives a flavour of what the ICB works upon. And then I'm going to just ask my partners, Alison and Sue, just to give a couple of top lines from their slides so you can get a flavour from that, and then we'll come back to some questions. Is that okay? Thank you.
Afternoon, everybody. So my name's Sue Burton. I'm Deputy Chief Nurse. Nursing and Midwifery Excellence is in my title, so I sit nicely with the patient experience agenda as well. We work closely together within UHL. We popped 2 slides into there, very much patient feedback focused, about the ways that we obtain patient feedback. And I'd like to draw your attention to the positive scores that we've got and how we benchmark those against not just regionally, but nationally. And some ideas of the work streams that we popped into there. So we pulled out work streams from the last feedback that we received in 2023. And we pulled out specifics around inpatient care, around sleep promotion, nutrition and hydration, part of the maternity improvement programme, and a piece of work that I've been leading on about improving fundamentals of care. I think the other key point that I really wanted to draw your attention to is on the second slide. We've been doing something called 15 steps assessment, and this has been heavily led by our patient experience team, but actually each of these 15 steps is accompanied by either a volunteer or a patient to really try and understand the focus from the insights from a patient's view and patient perspective. And I think that's been one of the biggest learning that we've had across the organisation over the last sort of 18 months, is getting that different perspective rather than a staff or a colleague view experience, actually understanding the patient experience. They're the 2 items I wanted to raise, so thank you.
Hi everybody, my name's Alison Kirk. I lead patient experience and involvement with Leicestershire Partnership Trust. So obviously slightly different focus in terms of our patient cohort and our service users, and particularly around sort of our approaches. But we have some similar approaches. So I'm not going to take us through everything that we do, but I think, again, drawing you to some of that attention really around our scores and actually the number of feedback that we get. We get an increasing amount of gifts of feedback, really, but actually the challenge is how we really put that into something that's really, really meaningful, particularly when people are giving you a narrative around that. But over 23-24 as a trust, our sort of positive feedback isn't as high as we want it to be. We had 87% positive feedback through our friends and family test, which is that old formal, would you recommend this service to your friends and family? But I think a lot of that is around the acuity of some of our mental health provision, and a lot of our feedback and a lot of our negative sort of feedback that we get is particularly around our mental health services, because of, I think, sometimes around, particularly since COVID, the acuity of patients that we're getting across the city and county. However, saying that, I really want to draw everybody's attention to the fact is that 3% of everything we hear is negative. Actually, 97% of everything we hear is positive. And what we don't do, I think, effectively is probably look at the good things that are happening and how do we spread and adopt that. So I've put in a little bit here about how we look at our experiential element. We look at the sort of relational aspects of care, and also then about the emotional aspects of care. And we know it's the relational aspects, so our systems and processes, that normally are letting people down. People fall between the gaps, either long waits, referrals, etc. But actually, when we look at our the care that's given as an organisation, we know that people actually report a really strong experience of care, and that's something that I think our workforce need to be quite proud around. Just wanted to bring you to a bit the so what. It's like Jenny's covered, you know, it's great having all of this insight and intelligence, but actually what do we do with it? Actually, how do we turn that into improvement? So over the last couple of years, we've invested heavily in trying to build our patient care and lived experience voice at every level of the organisation. So that's about how you can have a voice in your individual care, right the way through to having lived experience partners, the patients and carers that we pay, they're employed, and they sit and work alongside our key decision-making bodies across the trust. And they are there to give that perspective, to actually to challenge and confirm in terms of the view of the patient and the carer in the room. Really just some highlights as well in your slide deck around some of the things that are how we're now projecting that voice forward in terms of our framework for that lived experience across the trust. And as you can see, we've sort of got good partnership working with colleagues such as Healthwatch, where we've established something called our People's Council. So that's people with lived experience, voluntary sector, community members, Healthwatch members that sit there alongside our trust board and actually act as a critical friend with our trust board and to ask some of those obvious questions around experience. So I'm hoping that we've given you a bit of a sort of a high level view in terms of the amount of feedback we've received, some of the themes and trends, but more importantly, what we're doing with it, because it's the so what is the key thing I think that we're trying to answer in terms of the experiences of our patients and carers. But happy to have any questions on that. Thank you.
Thank you. Fiona, I was going to say, do you want to do the Healthwatch bit as well?
Thanks, Chair. Yes, and thanks, colleagues, for sharing your insights. So Healthwatch comes at this from a slightly different perspective, as you can imagine. Healthwatch is an independent body. It was set up under the 2012 Health and Social Care Act, and it has a role, I think it was once called local consumer champion, but the basics are that Healthwatch operates outside of the system. It talks to people who use the system. It captures their insights, their feelings, their experiences, and does something with it by feeding it back into the system and then checking up with the system a little bit later what the system has actually done with that feedback. And that's kind of the feedback loop. Just to give you a flavour, in the last 18 months or so, Healthwatch has carried out lots of public events where it has met people face to face in conversation around the county to ask them for their experience of using services, both NHS and also social care. They also carries out pieces of work. It carries out things like insight reports. For example, in the last 18 months, a flavour for those would be accessing healthcare services for asylum seekers, ethnic voice, community voices on health and social care services, LGBTQ+ voices on health and social care services. So those members of those communities, find out their experiences, put that in writing and then share it with providers of services so that they can understand how different communities are experiencing their services. We also have a statutory obligation to carry out enter and view visits. And in the last 18 months, 2 years with the NHS locally, we've done those visits for gynecological services, learning disability, patient experience, the adult side, children's ED, adults ED, community diagnostic services, and various GP practices across the county. Now, those enter and view visits are undertaken by trained volunteers who go in with by appointment to understand the accessibility of those services, have a look at the physical location of those services, the signage, the accessibility, they look at the staffing, they look at communications, and they come together, pull all the information together and come up with a number of recommendations dependent on the service. Those recommendations are then part of the enter and view report, which is agreed with that particular provider. All the Health Watch reports, both Insight and Enter and View, are published, once agreed, on their website. So they are easily accessible to all members of the public. And at a point, probably 6 months to a year after those reports are published, then Health Watch will go back to the providers and say, we found this, can you tell us what you've actually done with that? So we can close the loop on people's experience. Health Watch also is required to provide an information service for people in the community. This is a telephone line as well as online inquiries, and it's used by people to ask about different services and how they access it. It's also used by people to share their experiences of health and care services. By and large, people generally have good experience once they're into the system. Most people are complaining about the access into systems, the time it takes, or the ease it is to get appointments, whether it's GP or secondary care. Once they're actually in the system and getting that experience from primary or secondary care, then they're normally very happy with it. But I think what you can say realistically is that from a Health Watch perspective, we are very much the people that can close the loop with people in our communities about how they access and what sort of service they find when they get there. Health Watch is also usually part of consultations or promoting consultations about the services and making sure that people who are going to be affected or who are going to use those services are actually part of the conversation about what sort of service they would like to see, how they would like to access it. And you will find that Health Watch is part of those consultations, but not only in its own right, but by providing access to people in communities who should be part of the consultation. For example, today we've published the link to the County Council adult social care strategy on the website, so we can encourage people to give us their feedback. Well, in fact, that one will go direct to adult social care. So that's the sort of closing the loop as an independent body over and above the NHS providers who we have with us today. Thanks, Chair.
Okay, thank you very much, Fiona. So fair amount in the paper. So first I saw for a question was Trevor.
Thank you, Chairman. Gosh, this is so easy, isn't it? We can nitpick all day. Seriously, it's hard work, and I appreciate that. And we're good in Britain at nitpicking, aren't we? Right, in the waiting room, I will be honest with you and say is about the only time that really I worry about services. So if I'm accompanying my wife or I unfortunately happen to be in there myself, nevertheless, I'm looking round. And one of the things that I love to see is a "you said we did" feedback. And I think that's absolutely great. And I noticed it at Leicester when my wife was treated for her cancer. And I also noticed it in Nottingham when I happened to somehow by my GP surgery be drifted to that Rushcliffe area. They both do it and they both did it well. But one thing I didn't notice, and I'm quite interested in this, is trajectories. Because it's okay to say, as far as I'm concerned, you said you did, but over what period of time? And is the trend this way or this way? Because a lot of things for me would be, okay, I got a bit of a rough deal here. I'm waiting for 45 minutes. The surgery is running behind schedule. Is this still the same? Was it 10 like that 10 months ago, or what? Is it coming down? If it's coming down, okay, I'm cool with that. If it's going up, I'll register a complaint because something's not right. I just wondered, long ramble, I know. Is that the case that you can give trends in that sort of feedback? Thank you, Chairman.
So I appreciate we've got 4 people potentially who might want to actually answer that. So I'm going to be fair and just say we'll have one person answering on behalf of all 4 to each of the questions. So you're going to have to arm wrestle between you which one is the best one to answer. Okay.
I think I'll take that one. So certainly from a UHL perspective, so we track all of that. So we track our trends in things, but I think it's a really good point about how do we articulate that to the person that's sat in the waiting room. And I think that's something that I'll take back and I'll feed back to our head of patient experience and say, how do we articulate? Because you're absolutely right. You said, for example, there aren't enough chairs in the waiting room and we provided more chairs. But when was that? That could have been last week or it could have been last year. So I absolutely take that point. So it's something that we break down as part of our patient experience questions. But do we articulate that back to you as patients, relatives, etc. coming in? And I hear your point. My mum was in hospital in UHL in December and I did exactly the same. You sit there, you look around and you think, what can I see? You know, how am I going to improve the care? Because you take it back. I take it back to my own colleagues then. So yeah, I'll take that back as a theme and I'll take that back as a point and try and work out how we can do that in a timely fashion.
Thank you, Chairman. I'm absolutely delighted with that response. It's super.
Cool, that's a happy customer. Okay, we'll go on to Mike. If you want to ask your question.
Yeah, I mean, I suppose this is here because of my request. I wanted to know what people think. I wanted to know what the public thought and how they were given the opportunity to think as well. And it's nice to see how it's fed back through various bodies and organisations, collated and actions taken. At some point, all of us come into contact with the NHS at some point in our lives, and we will have a view on how it went. A lot of it goes extremely well, which is pleasing to hear because it gets knocked too much in my view. I suppose I've got 2 questions, one for that table and one for Fiona. When do you get this feedback from patients, not GPs, I mean, hospital setting, while they're undergoing assessment and treatment or after they've left that environment? Because I know the pressures on the staff are immense, and this probably is not a priority to ask the patients, what did you think? I get that, but it's important we understand what they're thinking and what their experience is. So I just wonder, is it when they've left the setting that we ask them, what did you think? Or when they're in the setting, when it's probably more pertinent? And I'll come on to Fiona in a minute.
Thank you. It's a really good question. And I think it's a mixture of both. So we have something called the Friends and Family Test, which essentially is a post-appointment or a discharge. It's the survey that follows up. So it's once somebody's had that episode of care, for want of better, or that appointment. But obviously for our inpatient services, and particularly within mental health, we have inpatient services where we'll have people with us for many, many weeks and many, many months. So, and it's really important to understand that experience during that length of stay. So a couple of examples I'll just give you. Within our mental health wards, what we have is something called a community forum. So they are weekly meetings where the staff and the patients come together and they discuss the ward environment, what's happening on the ward. That might be about food, it could be about call bells or anything, but that's an opportunity to have ongoing conversations whilst people are within our care. However, we do also have patients and carers that are on the ward that don't want to speak to us as an organisation for the fear that their care might be affected. Again, somebody that maybe is submitted through the Mental Health Capacity Act. So again, that's where we work with our partners such as the CQC, so the Care Quality Commission, where we do get concerns raised directly through maybe with visits that come through the CQC, and that we have a route in where any concerns and questions that come through, maybe through a family or somebody whilst they're on their ward that don't want to address that with the ward staff themselves, there's a route that they can come through and they can have their concerns raised. Just a final point in checks and balances, I think that's where the 15 steps can come in really well. Just about, if you've got, as you said you did on the ward, and you've got patients coming in and going, well, you said you did, we can't see that happening. It's a really good way of checking on some of that stuff. So I just wanted to get that in as part of my response. So yeah, thank you.
Mike.
Yeah, brilliant.
Round two.
Thank you for that. Yeah, I think this is Fiona. I think it's on page 38. It was the Health Watch survey. I can understand why 56% may be dissatisfied with the outcome of their complaint. I'm just wondering why 56% are dissatisfied with the process of making a complaint. Was there something behind that?
This is the survey carried out at national level by Health Watch England. So I can't tell you exactly why that would be, but I would hazard a guess because there are all sorts of sensitivities around patients making complaints against the NHS. Part of that is in relation to people, and you touched on this very briefly, Alison, people fear that by speaking up, then something adverse will happen to them or to their course of treatment. So there is that element. And the second element is that making a complaint and putting their head over the parapet involves speaking to somebody, maybe somebody from PALS, maybe somebody on the ward, and to do that in comfort can be quite tricky because not everybody is trained or supported to hear and receive a patient making a complaint. And sometimes the interaction between the two people doesn't go very well. And that is the other side of being negative. Those are the two issues that I am aware of.
Actually, can I ask a follow on from Mike's first point? So the friends and family, and we all obviously get the text message every time we go to a GP or we go to LRI or any of the other services. And I must admit, the tendency is usually you get 3 questions. Actually, it was okay. I'm not going to bother responding. And somebody made the point earlier on, which was we have a tendency. It wasn't actually Trevor, but I think Trevor would probably agree with this. There's a tendency to actually only respond when it's something's gone exceptionally well or exceptionally badly. And maybe Mike's point about 56%, Fiona's answer, I suspect that probably if you're really, really, really upset or use stronger language than that about something that's gone wrong, you're just going to say no to everything in the sense that it's really gone badly. I don't like the complaints procedure. I don't like that, etc. The Friends and Family is quite an automated service, and it's obviously it's not unusual in the UK these days for retail or for NHS to actually use a quantitative research response, and you get a lick-up scale score, and then as a result, it's nice and easy because it's actually numbers and it's data, and it goes in and you get a percentage out, etc. And it's a very easy way of collecting quantitative data. The issue probably is the qualitative, and I suspect to a certain extent that's probably where Health Watch comes in with some of the sort of research they do. But the question is how as an organisation do you actually sort of to a certain extent poll the patients to actually understand genuinely what the qualitative responses may be to either the lack of response to the quantitative data collection or alternatively a follow on to actually understand behind the data why somebody's given a 3 out of a 5 it's a type response rather than actually a positive or a negative.
Yeah, thank you, Chair. So I think that when you look at the Friends and Family, for me, and I think it was always ever meant to be a bit of the tin opener. So what the Friends and Family should do is just to point you maybe into a direction of where you're seeing a bit of a theme and a trend. Oh, well, over sort of the last couple of months, we've seen a bit of a theme about dissatisfaction about Service A or Service B. So certainly it isn't the be all and end all. For me, that is a bit where you take that evidence and then you work with that service to say, these are the themes that we're hearing. How do we then triangulate that maybe with other data? Do we look at our complaints data? Is that telling us the same thing? Do our PALS concerns tell us the same thing? Also, we look at things, maybe is it because we've got low staffing numbers within a particular area? So the aim is about how we start to look at that data in a little bit more detail. Some of that might mean we need to go out and do more engagement. But that to me is the trigger point where we start to bring in that lived experience, that patient and carer voice to work with us to say, this is where we're seeing a bit of a thing. We might want to do something about it. What are the things that we need to be looking at? So you're right, the friends and family is that sort of tin opener. It's mass numbers, but it's not, we certainly don't look at that in isolation. It's the first thing we look at to then think, okay, what else is telling us? What is the causation? And then how do we then go and work within that particular area or service to do that deeper dive? I hope that answers the question.
Nick.
Thanks, Chair. One question like regarding there again about text messages you get every time you've been to the doctor and everything else. Is there a limit to how many text messages an individual gets each year? Because if you're going for repeat formans, you could be saying, yes, it was brilliant. You turned up, had an injection, you got home. And you could probably get 100 a year if need be. Because like sometimes, like you see at the airport where you get the smiley faces, you see the kids there pressing every single button 500 times. So the data is kind of can be useless if it's not done correctly and limited to the amount of people who do it. So how do you control that, please?
Thank you. Yeah, I think it's called survey fatigue. And I think it's quite well known that the more appointments somebody has, the more time they get asked something. So we don't just use the friends and family. We've obviously got the National Patient Experience questionnaire as well, which is a really quite detailed questionnaire, which goes into sort of levels. And actually that gives us more of the quantitative data you were talking about. You can have multiple. I don't think there is any cap, as far as I'm aware, to the number of texts, or is there? This is the expert. I'll hand over.
Sorry, yes. So what we've built in with our friends and family test, you're right, because particularly some patients in the community might be receiving multiple services from multiple health professionals. So we have set, when we extract the data from our system to then put the alert in and the text follows, we have a flag that actually there's a limit of 2 surveys that can go out. So you can put that into your FFT provider. Will put an element in, so you're not over surveying people, and I think every system will have that. So we try to do that, but you're absolutely right. If you've got somebody that could be receiving GP FFT, an FFT from friends and family, from LPT and from UHL, and that's when you get the apathy in the system, and people sort of get that for survey fatigue. So, but there are measures we do put in, and I'm sure every trust would be putting those in as well.
I'll find out for UHL.
Now you'll know, Nick, precisely how many times you respond to those messages. Fiona, you've got a question or yes? Perfect.
Thanks. Sitting this side of the table now. It's a bit hard. So one of the issues that this highlights, I think, this presentation, is that here we have 2 massive providers, UHL and LPT, here with a really comprehensive patient insight structures, are very able to get the insight, churn it around and do something with it. Fantastic. But one of the key issues for us is also that out in the county, we have 100+ GP practices. Each one is an individual practice. And of course, they don't have overall the same comfort umbrella of the size of UHL or LPT, even though the ICB is a corporate holder or corporate overseer of GP practices. So the issues that patients and the carers and families have around GP practices are not always as easily understood, except through the massive GP survey, which doesn't necessarily focus down at individual level, and understand the experiences you might have if you went to a surgery in Colville against a surgery in Melton or one in Market Harborough, and have those really drilled down experiences. And that's, I think, a little element that we can't quite nail at the provider level. Thanks, Chair.
So I've referenced it during the slides actually, which was last year, we as a system decided that we wanted to absolutely delve as far as possible, and the team led that, which is where we actually went out locally to ask with our GP practices, as you well know, because we presented it here, exactly that. So I don't know if you where we got an incredible amount of feedback, which was because we worked with our GP practices and through our PCNs to actually engage with everybody if you live in Leicestershire around here, and that's the survey that we got 29,000 plus responses, which is a huge amount compared to the local one. The questions mirrored some of that, so we could really delve. And then what that allowed us to do is not dissimilar to what you, exactly as you described, which is brilliant, which is what you want from those insights. That information then gave us something to then triangulate with the other information that we know, which is not dissimilar again. What do we already know about those GP practices? What can we align with our complaints procedures? What can we see in regards to what we know about those practices where we already know that they've got red flags? And then what that's allowed us to do in the last 12 months, which has been fantastic through the primary care team, who are really involved in this, is work with some of those practices. And we've highlighted some of those that did incredibly well, which Neil can talk about a bit more, and those that have perhaps needed a bit more support in those spaces to allow us then to add that value into that space. The work that went into getting that very large number of responses is something that took a lot of resource, if I'm honest, and it is, and as you will know from your from Healthwatch, getting that amount of people to respond is difficult, and it required a lot of work from our practices. So it was absolutely a team effort. So when we come around to doing these things again, we're going to have to be really mindful of that when we do it. But the value on it that it's given us has been really helpful. Neil, I've probably covered it in my way. Do you want to make sure I've done it right?
No, I think you've got it very extensively. I think, and every practice also has its own friends and families. So we don't put a cap on ours. Ours are continuous because your consultation will be very different with a different practitioner. So we don't cap ours. All practices do that. There are the surveys that Jenny has outlined. Practices can also choose to do their own survey. They have a particular issue. So they're consulting or engaging on a particular service change. They will do that and evaluate that. We have a range of patient participation groups. They vary, as colleagues will know. We've had that discussion before about the quality of those within different general practices. We've also done a piece recently, and I think it's your point about celebrating success as well as where things don't go really well. And we took the 10 top practices on the patient survey across LLR. We have 126 across LLR, so this is beyond county. But actually, most of them were in the county. I'll just make that point. And we convened a group to say, what are you doing so well? We have some that were top in the Midlands and a couple that were top in the country, in the top decile of the country in terms of patient experience. So we did a strengths-based approach to say, what are you doing so well? So Jenny's team led that with these practices to say, what is it that your patients find so amazing about your service that you get literally, absolutely amazing feedback on a regular basis? We're now in the second phase of that to say, after that learning, how can we buddy up with those in the lower decile and how can we support them to improve their experience and their patient journey? So we're doing that buddying process to say, what is it? Usual things, communication, access, and then the ability to understand the range of services and changes in services that patients really appreciate. So we've got a very similar approach to the trusts. It's not always as visible because it's at a unit level per practice. But then we also do primary care network surveys as well, sometimes on a particular service or service change.
Very good to hear. I have to say, the particularly taking the absolute top performers and being able to use that experience. So we've got a couple more questions. We've got Bessie and then Ross. Did you want to come in as well? Okay.
I think the thing that's often brought to my mind by residents is the lack of communications with GPs. They feel the GP practices are quite remote, and we do have a good GP practice where I live in Shepshire. It's excellent actually, but there's still an issue, of a communication issue between residents and patients and the practices themselves. And the practices are very, very busy, as you can well imagine, but it's how you overcome that lack of communication and just little simple matters. Sometimes, I don't know whether the text or Facebook or whatever, whether they would look at sort of widening out their means of communication so that patients actually feel that they're part of it all. And I think there is an issue of people feeling isolated. What one does about it, I don't know. Thank you.
Does anyone want to
very practically, absolutely aware of the fact that the challenges that the population faces, certainly in regards to isolation, which is something nationally that has been talked about all the time. And I think what you're describing is something really important, which is around the fact that we must be focusing on those people that live in our neighbourhoods and how we make sure that at that place level that we're really involving and making sure that we're doing all we can to communicate and engage with people so they're aware of what's available to them. That isn't a quick fix as you're describing, and we've not always got all the answers, but what we're trying to do exactly through all of this is continually talk and engage with our people that live and work in all these places to keep supporting that. And as Neil sort of highlighted, is that all of our GP practices are individual. So some of them will be incredible at some things, just as everything is, and not so great at the others. But exactly as Neil's described, taking some of that best practice from some of the practices that are doing some things well and sharing that with others means that we're constantly looking to lift up everybody into that space. But if you've got anything that you want to contribute and talk to us afterwards, that'd be brilliant.
I mean, I come from a medical family myself. Wouldn't like to tell you how many doctors and nurses I have in the family. But there does seem to be out there. I don't know how you resolve it. It's an issue, maybe. I don't know whether local newsletters or something would help in some sense. But does seems to be that barrier between what the GPs do, and they do very well, and how the public perceive it. It's those public perceptions, how you manage that. I'm not sure. I'm not criticising the GP practices because I've got an excellent one in my home patch, but there is that communication issue, and as I say, how you resolve it, I don't know. Thank you.
Thank you very much. Ross.
Thank you, Chair. It's interesting when you think about the services you've received from the NHS and you talk to your friends and family. On the whole, I think the feedback that I've had is incredibly positive, and that's reflected in the scores that we've had. I think if you read the news, you'd think the bottom is falling out of the NHS, and it's clearly not based on the feedback that we've had. And it's pleasing that we're better not just than our peer trust, but on our national averages as well in every domain. And so first of all, I wanted to start with the positive and say well done on that. I was going to ask a question on the quality of feedback versus the quantity that we're getting, but I think we've covered that already. So I'm going to slightly change the question to ask, how do we ensure that we're setting the scene when we're getting feedback? So if I pose a scenario, if you go to A&E and you say the wait time for A&E is 2 hours and you get seen in 90 minutes, you think, oh, they've done a really good job today. But if you say the wait time is 60 minutes and they get seen in 90 minutes, they think, something's slipping, they've not done very good. Now, when asking patients and residents for feedback, you can say, what do you think should be done? And they'll say, more staff, more facilities, I want a GP in every village, which is great. That's a blue sky aim. But realistically, within the financial constraints and the capacity constraints of the NHS, it's not realistic at this point, is it? So I'm just wondering how you put into context and how you set the scene when you get feedback to ensure that it's quality feedback.
Wow, that's a big question. I think it's a little bit of everything that we've already discussed, isn't it? It's about having that dialogue and having the right comms with all of our patients, being able to talk to them directly, get the feedback then and there. I think we try and aspire high, don't we? We always try and aspire high. And yes, we would aspire that somebody comes into ED, gets treated and is out again within 60 minutes. But we know the reality probably isn't going to be that for people. So I think the comms on the shop floor, being able to talk to people and saying your wait is probably going to be. So as a nurse, I can answer this from a nursing perspective. If a patient came into a clinic that I was holding, I think we need to say your wait is probably going to be 4 hours. It might be that you want to go and put a little bit more time on the car park. It might be that your loved one wants to come and pick you up from that exit. I think from the forefront, I think we need to make sure that we're ensuring all of our teams are comfortable in doing that. I think if you come in and you have no idea, you don't know where the car park is, you think you're going to be there for 60 minutes and actually that you're there for 90 and somebody needs to pick your child up from school. So I think it's about everybody in the NHS being able to take a little bit of an ownership of their own area and articulate the challenges that we've got. Because I think people, whenever I've had conversations with people, there've always been a lot more, particularly people who have complained, and I'm thinking of all the times I was a matron and a head of nursing and somebody might raise a complaint with me. It all comes down to communication. I think 90% of the issues that I've dealt with are communication, and if only we'd said this might happen to you or this might not happen to you or your next steps are and this is where we want to take you, So in my belief, I think that comes down to communication and making sure we're giving the right messages out there, whether or not that be across the whole of us as the ICB, us working together as teams, but actually right down to the shop floor level, and each practitioner knowing that they can have those comms with people.
I'd just add one more thing on that, actually, which really good response and great question. It's also the language of when you're finally actually being seen. It's also the opening language so the number of times that you've maybe had a 45 or an hour and a half wait, and then you finally get in to see the medical practitioner or the consultant, and the first thing they say to you is, I'm absolutely rushed today. It's been an absolute nightmare. It's awful. I'm so busy, because instantly your feeling is, I'm not going to be given time, because actually they're too busy to see me. So sometimes that response is actually quite difficult to quantify when you're filling out a survey or when you're talking to somebody. But actually that patient experience is really quite important to actually get it right, so that somebody actually feels that if this may be they're only 10 minutes in the year, they're actually seeing someone, but at least they're actually being heard and they're being listened to. Ross, did you have a follow-up to any of that?
No, I think you hit the nail on the head in the response. I mean, I shared to this committee previously, I had eye surgery before in December. I've been having quite a few reviews at the LRI since. And I went to one a couple of weeks ago, and the appointment was 3 p.m. And I got there and it said, oh, we're 2 hours delayed today. And you sort of roll your eyes a bit and you think, okay, well, I've got an appointment at 3 p.m. Why we're 2 hours behind? But at least, and you think you accept it, and what am I going to do to change it? Nothing. So you feel much better the fact that they're going to be 2 hours behind. So I think you're absolutely right there.
At least you still had your eyes to roll.
On both of those points, I think the answer is, I'm really sorry that you've waited 2 hours for this appointment, but you're here now and I've got the next 15 minutes with you, and I want to make it the best possible experience that you can have. So tell me exactly what it is I can help you. You're absolutely right. It's in the language that we use, isn't it?
Just add one more point to that, because I think it's absolutely valid. And I think that's why we're trying to bring more of that lived experience voice into service design and planning, because actually coming from that perspective of, I have walked in, the clinician's treating what's in front of them, but actually you as a journey, you've had a nightmare getting in, you've had to park your car. So bringing that lived experience voice into when we start to plan and design service is also really essential. So I think, that's one of the things that we're really much focused on, and I know it's across the whole health system, is the importance of perspective and bringing that perspective into the room, because actually together we can probably plan the more effective care and the right communication. So just really to reflect that point back as well. Thank you.
Thank you. We've got two final questions to come in. One is from Brenda and then Louise as well.
Thank you, Chair. Mine wasn't really a question. It was it is and not. It's I think Betty broached on it. It's perception, isn't it? And we are increasingly we're more impatient now than we ever were, and we're not prepared to wait. And I've got a husband that's a decade older than me, and we not long went to hospital, and I drove him, and I go there with a book. I've got the perception, I understand it's hospital, that things happen, people go in front of you that you think is unfair because you were there before them. So it's the communication and the perception of it. As I say, I take a book, and I think the last time I did some embroidery, but he's just sitting there, just watching everybody. And then, they're going in before me, and so on and so forth. But yes, you're right. The ticky-tack sign at the top saying, the waiting times was good, because we just wandered down to the canteen and then wandered back up again and filled that particular time. But there is one thing here, that when I went in for a fracture, the fracture clinic, why is it so far away from the x-ray? I've got a fracture. I've got a fracture. It's obvious I've got to have an x-ray, but it's right on the other side. So that complaint came from me, because it was planned badly, obviously by a man. When you get into that mood.
Exercise is good.
Not when you're fractured and that. So It's just the planning, and you just think, why is that over there and this is over here? So that's my comment. And as I say, it's perception, and it's what we're there for in the end. So thanks.
You sound like my wife. I'm always the one that's actually done something wrong, even when I haven't even said anything. But there you go. Right, Louise.
It was just a comment, really. I think a lot of things could be easily diffused. If you've been waiting a long time, just have a short apology from a consultant or whatever. Quite often they are very focused on they're very, very busy. But if you just say, I'm really sorry you've had to wait, that completely diffuses the issue from the word go. And it's a very simple thing to implement.
Yeah, communication is absolutely key, and the lack of communication can be devastating. So I absolutely agree with you on that one. Absolutely agree with you. Okay, look, everyone has asked a question. There are loads and loads of questions that probably could be asked in addition. I think Trevor's opening line, which is, you know, it would be extraordinarily easy to actually go through every single line and ask points. But I mean, the purpose of this is to really get an idea. Mike, absolutely right. He raised this as a query a while ago. So it's a good opportunity. As always, we are a very responsive committee in the sense that, you know, our papers come on the response to points that have been raised or raised with us. So this is a good example of that. So thank you very much for giving us a really good session. And hopefully we've all gone away with a little bit more information about whether it's about Ross's update on his eye appointments or Brenda's X-ray trips. But really, really good. Thank you very, very much to all of you. Fiona's obviously going to be staying with us. But otherwise, for the three of you, thank you very much. Okay. So now we are going to be moving on. So now I should thank you very much. You're obviously staying with us. Rachel is joining us. Rachel's from the ICB. So I think at this point, for anyone who's been on this committee long enough, you may wish to turn over Sue's, because otherwise we have a knack of accidentally calling the wrong person by the wrong nameplate. So apologies for previous performance on that one. So what we're going to do now is discuss the overview. Well, this is the overview of the UEC offer outside of the LRI site. This is a paper that we've asked for really from a perspective of being county HOSC. So we're obviously interested in the offer as effectively in relation to the county area. And it's always it's a good point is to on sort of the population side, and we have this discussion obviously at Joint HOSC as well, which I chair, where roughly a third of the population is within the city boundaries, about 360,000. There's about 720,000 people in the county area, and about, I think it's about, Fiona probably knows this better than I do, I think it's about 35,000 in the Rutland area. So they're roughly the sort of the population centres. So in relation to outside of the city area, 720,000 is a fair number of people. I think UHL is still, I think it's the highest, is it the highest density hospital site in England as far as the number of people that actually access it. So it's a very sort of intensive site, but obviously 2/3 of that intensity is coming from the county area rather than actually directly from the city. So as always, if you want to spend the next sort of couple of minutes just sort of outlining some of the key points or teasing out the key points, and then we'll go into questions. Thank you.
Yeah, thank you, Chair. So I'm Nil Sangani, Chief Medical Officer of the ICB, and I've got Rachel G with me, who's Associate Director for Integration and Transformation with the ICB. And as you say, it was a follow-up question, I think, on the back of the last UEC presentation we had, where we were talking about the pressures we'd had over winter, the critical incident we'd had back in the autumn, but to focus in on the county provision. First thing I want to say is the breadth of urgent and emergency care services. So you'll see from the first slide in the pack, we've tried to describe the different access points that people have to our urgent and emergency care system. Now, urgent emergency care means one thing to us on the clinical and ICB side. It means something different to patients. So from a patient perspective, if your problem is really pressing and challenging for you, it's urgent, it's an emergency. We may not clarify and describe it in that particular way from a clinical perspective. But I think it's really important we take it from a patient perspective in terms of their journey, because if it's urgent to them, then we need to make sure they can be seen in a swift manner. The reason I'm drawing that point is you'll see from the data that actually a significant proportion of the cases that go through our urgent emergency care pathway are actually what we would call primary care type cases, so they could have been seen in primary care. And in fact, across the county, 42 to 45% of our patients are seen within 24 hours of booking appointment, or 48 hours at most. So that's just under half of our patients who can get an appointment within 48 hours, which I think when you see it like that, that's quite impressive, considering that a significant number of appointments for primary care aren't needed to be seen with that level of urgency. What's also really important is that with the advent of things like pharmacy first, we've got 7 really important conditions now that again often are quite urgent for patients: an acute sinusitis, a water infection, some other infections, earache in a child, for example, that can absolutely be considered urgent by our population, that can be dealt with by our pharmacy. So what you're seeing here goes beyond what a lot of people might consider as urgent emergency care. So when people think of UEC, they think of the emergency department and they think of ambulances. It's far broader than that in terms of that provision. So we've described some of the means into there. So Fiona was talking about the difficulty sometimes from a patient experience with access into the system, and that can be through 111, it can be through the NHS app, it can be through conventional routes like telephone booking, but also increasingly through online consultations. And what's really exciting is some of the artificial intelligence online booking that we're doing and trialling in some of our practices in the area. You'll see the primary care provision, so pharmacy, dentistry, optometry, as well as general practice that we consider in the wider primary care. And you'll see in the pack also the range of different urgent care centres that we've got in our different districts and boroughs across the county. So we have some form or other covering the majority of the county patch. What's also important to just make note of is that the county borders other counties and other parts of the Midlands. And so when we plan our services, we also think what's just across the border, what's in a neighbouring area, whether it be Coventry and Warwickshire, such as the George Eliot, for example, with its urgent care centre, or Swadlincote for those in the northwest Leicestershire and South Derbyshire part, for example. So we've got lots of provision outside of the county that our county patients also use within that. As well as the primary care element to this, we've also got a really important element, which is particularly for our frail and elderly population. We've got a significant frailty pathway. So we've got the ability for a patient in their own home to be visited by a home visiting service. So you'll see that the thousands of home visits that occur by a service that we can commission through Derbyshire Health United to visit our patients both in hours and out of hours, to keep them at home and get them seen and kept at home wherever possible, avoiding hospital admission. We also have something called the Urgent Community Response Service. Again, over 12,000 patients are seen in their own home with a response time of less than 2 hours. And that's our community nursing teams, our therapy teams, and our adult social care teams working together, so through the county council and private providers working together to keep often our frail and again elderly patients at home with a community response to their urgent need. We have mechanisms to reduce patients needing to go into hospital by our work with East Midlands Ambulance Service to do what we call hear and treat, where they get a triage over the phone by the ambulance service and a direct episode of care being completed, or a see and treat where the paramedic goes out to their home and is able to deliver care at home and avoid them going in. And we've also got another mechanism now to take calls off our emergency ambulance service list so that those patients can get a quick response to the community where that's more appropriate. So I think what I'm describing overall, and Rick, please, Rachel, do come in, it's a breadth of services covering most of our areas, many of them also digital, telephone or other means to get in for our patients, and a whole range of different offers that we've got for our patients according to their need. The other bit that wraps around this, it's really important to bear in mind, you will be very familiar with 111, is something that links to that, which is our clinical navigation service. And just as the title describes, it's navigating patients to the right place at the right time. This is incredibly complicated, even for people like others who work in this. Knowing where the right place is to go for the patient is really difficult. So to navigate patients to the right place first time is really important. What we aim to do is to stop bouncing patients around the service and around the system, wherever we possibly can. Sometimes that's not the case. You might have a patient going to a minor injuries unit and then realizing actually they did need an X-ray, they did need something more complicated, and by definition then we have to refer them on to the next service. And we've also got some services that have a greater range of facilities than others. So Loughborough Urgent Care Centre open 24/7, X-ray facilities, point of care testing, you can put plaster casts on, you can do all sorts of things at Loughborough Urgent Care Centre. And then our minor injury units that again in Oakham and in Market Harbour have got X-ray facilities as well. So a range of offers and a range of services.
Yeah, thank you. So as well as my role as AD for integration and transformation, I am also the place lead for Leicestershire. So from a county perspective, work really closely with colleagues to talk about the provision that we have and to work through the provision that we have. Slides 4 onwards kind of go down in a phase of severity, if you like. So the people with the most severe needs that aren't ED related, we would expect to attend an urgent treatment centre, and that's where they'll be directed. There's 2 of those. There's Loughborough, which is 24/7, and then there's Oadby, which works over reduced hours, but people are signposted to those services appropriately, dependent on their level of need. We've then got the 6 urgent care centres, which are a slightly lower acuity and won't have the same level of near patient testing, but they are available for patients who can't necessarily get into their GP same day, or who have a slightly elevated need, just to make sure that we have that availability for patients. And I think it is really important, the point that Neil made, in terms of our boundaries are very false boundaries for people. So actually from the centre of Hinckley to George Eliot is 6 miles and a fairly easy journey. And I say that because I live in one of the villages outside Hinckley, and certainly at times of need, I will make a choice of where to go. We've talked also about the minor injury units. What I want to just focus on though, just for a minute, is that what we've learned through audit and data is that 50 to 80% of the activity that's going to these centres is primary care type presentations. So we absolutely need to maximise that pharmacy opportunity for people and really talk about that and shout about the positive experiences people are getting there. So a minimum of 10% and up to 30% of that activity could be managed by a pharmacy. And also that same day primary care offer, recognising that there is an issue about weekends, and extended access deals with some of that, but Sundays completely continue to be a challenge, which is why we're doing our same day access review at the minute to make sure that we have that equitably available. But those 4 services that we've described in terms of supporting those patients in the place that they call home, we've got some fantastic statistics about the difference that those services are making for our frail and elderly population and those with multimorbid conditions. And the more that we can do of that, and moving forward, looking at our neighbourhood models for the delivery of health services, we really want to champion and work more on those services that we can offer closer to the patient's home.
Thank you very much. Betty and Ross will come in soon. Can I just ask a point of clarification? Because the urgent treatment centre at Loughborough I know well from families sort of being taken there and etc. and using it. So the X-ray facilities that are there are not 24 hours. And I'm assuming that's the case probably at the other X-ray centres that are being cited, because I mean certainly we have accessed it for family reasons. Beyond, I think the X-rays are probably open for 8 hours or whatever it is on a I'm assuming it's a single shift support from personnel perspective. But otherwise, the direction is always you end up at LRI regardless. So there is a real, am I within the window that actually gives a complete access at Loughborough or not? And I'm assuming that's probably the same at Oadby as well. Otherwise, you end up elsewhere, which is obviously not great as far as the system is concerned, because you're trying to keep people out of the LRI and the emergency department.
Yeah, interestingly, we did pilot extending the X-ray hours over winter this time, and actually the need was fairly minimal in terms of those people who were attending Loughborough. What they do a lot more now is they will do what they call a strap and return, which sounds awful, but basically what they will do is make that patient immobile in terms of the area of concern, and then invite them back the next day to do x-rays for our least risky fractures. Obviously, if there's a more risky fracture, then they would be referred down to ED.
Which was, yeah, my son's finger was pointing in the wrong direction at one point, and that's exactly the treatment that he got, which was strapping and then coming back the next day, and a couple of paracetamol, and told not to be so stupid with a Nerf gun. Right, okay, Betty.
I've probably said this before. I mean, I've got my family members, most of them work in the medical profession, as I mentioned earlier. But I think one of the big issues, I think, for the public is the issue of communications in terms of letting people know what's out there. I mean, I live in Shepshed. There are 2 pharmacies. The pharmacies nearest my home is the best that was ever put on this earth. Absolutely brilliant. But people need to know how much a pharmacist can actually do, and that you don't always need to go to the doctor. So I think there may be an issue of communication, whether there's newsletters or social media or what, and that would save an awful lot of time in terms of appointments. As I say, mine is the best ever. Oh, right.
Thank you. Yeah, I think it's a really excellent point. I follow all the social media that we do as an ICB and across our system, and we are constantly talking about this. The problem I think we have is, and this is the population at large, is it's not the most exciting social media, if I'm honest with you. It's not what you really want to look like on social media until it's relevant for you, until the time comes that you need that. And then it's also remembering that. So I just referenced 7 services that now pharmacists can prescribe for that they couldn't previously. You're not going to hold those 7 services or conditions in your head until that's relevant to you at that time. So what we're doing also is making sure our GP services through, and this is where sometimes receptionists get bad press, they are trying to what we call actively signpost at the point of entry to the system. So if you go to the pharmacist with a sinusitis, for example, they may well say, you know, you can go straight to your pharmacist today and actually be seen and assessed for that, and if appropriate, receive antibiotics for that. So that's what we're trying to at that point in time. We are constantly on the communication and media sort of element, trying to make sure we do that. But it is a learning process, and actually the best learning is from yourself or a family member when somebody says, actually, I went for this and I got this, and then they promote that within their social networks more informally. But we are doing that constantly.
Ross. Oh, and then Louise will come in as well.
Thanks, Chair. I'm glad you said you live in a village near Hinckley, because so do I. And so naturally, that's where I'm going to concentrate. Thank you for outlining the difference between an urgent treatment centre and an urgent care centre. In Hinckley, we've got a pretty good NHS story going on, because we've got the CDC, the Community Diagnostic Centre, opening up pretty soon. We've got the day case unit approved. And we've got this urgent care centre as well. Can you explain to me, though, why the urgent care centre's just open 7 till 10? And what are people supposed to do in the other hours?
Yeah, so the urgent care centres are a bit of a catch-all. So now that we've got the extended access within our primary care services, we would offer appointments for as long as possible and up to 6 p.m. within our primary care services. So the idea of these services is to be available when those primary care services are not available, and for people who realise that they have an issue kind of later on in the day, so that they have somewhere to go. So it's really around failure demand and making sure that those people have somewhere to go for those lower level conditions that don't require them to go to an urgent treatment centre or to ED, but actually primary care isn't open or available to them.
And I think you said earlier, would you say about 40% of the cases here are primary care, so that they don't need to go to the emergency centre? And so you don't think there's sufficient demand there to extend this? Because there's a tier in between, isn't there? You know, above GP but below emergency centres. So you don't think the demand is there to extend the hours for this urgent care centre?
So we are currently undergoing a same-day access review, which is looking at that, and it's looking at all of the activity that goes through. So you can see that between Hinckley and Colville, we had 5,000, just under 6,000 appointments in the delivery there. We do look and assess at unmet needs. So where are those patients going outside of those times and outside of those hours? I think one of the key things that we need to do is streamline the access to all of these services and make it much simpler for people to know where they need to go. So we've got 2 priorities coming up in our 25-26 work. One is consolidating our points of access, because we call them SPAs, which is single point of access, but actually realistically it's several points of access at the moment. So we do need to trim that down. But also we are looking at how we consolidate that enhanced access offer within primary care and the work that our urgent care centres are doing to simplify that, but also make sure that we have adequate across the areas based on the data that we have available to us.
Could I ask that, it's possible to send me the information about that review that you're doing? Just because I think it's having a big change with the NHS services, and so I'll be really interested to know what's going on. Thanks.
Thank you. Louise.
Yeah, just a comment again about the communication. Something that just hit me in the face was, I don't know if other districts do it, but I know Blaby have a hook thing for, you know, when it's recycling, when it's thing on their bins, and people take notice of that and keep it. Is there a reason to actually produce something like that, which goes on everybody's bin, showing Pharmacy First where they can go for help? Because it probably will be more noticeable than something dropping through their door. Or, sorry, Jenny's waving at me, so perhaps she's already thought about it.
Otherwise, the cameras will never find you.
That's why she's coming today, but I've got you here.
So, we've only got so much money, and I completely agree with you. If we had a huge budget, that's absolutely what we would do. But where we can look to work with that, and we do all the time, is obviously work with our council colleagues and utilise the channels that they have to get out to their population. And we do absolutely loads with our districts, and the district council communications teams have been invaluable to us over this winter and previously. We've used a lot of their free tools as far as we possibly can. What might be useful, because obviously communications always comes up around this table, we've recently got a tiny amount of budget, Louise, and so what we've used is to do some really targeted work in really key areas, which you'll know we've done before, which is where we get into the real, they call it, there's a word, it's hyperlocal, but it's basically really getting down to the nitty-gritty of having looked at all our data. So a lot of what we've talked about today, understanding where those communities live, and literally looking at those addresses and getting into that, so we can really focus the money we have got into trying to give them exactly those sorts of things, memorable information. And we've done all sorts over the years, fridge magnets, you name it, absolutely. But if there's ever anything that you think that the council can do that they're using that we could be part of, then please let us know. I think the thing is that just like us, they haven't got a lot of money. So if we become part of it, they need budget from us. So from a practical perspective, we've got our hands tied, and that's probably very honest, but it's the truth of the point there.
But I'm sure all of the districts would probably work with you to design something that would be suitable for both. And if it's being kept in drawers or on a hook in the house or whatever, it's there for people to remember.
Absolutely. So, do you want to come in on this?
Yeah, just a quickie on the Get in the Know campaign. It's a really important thing that we've got. So if you just Google Get in the Know, it's on our LLR ICB website, and it's got all the health services in LLR, and it helps you find them according to your need as well. So the good thing with that is that we can update that. So if we change a service, we can update it. Obviously, the paper-based systems can't be updated quite so quickly. So the Get in the Know campaign on our LLR ICB website, really important to use and promote.
And all the districts linked to that as well.
I think on that actually, I'd just ask a follow up in that case, because it was interesting, the reference from Jenny about being hyper-local, or the ability to be hyper-local with data. And one of the things that when I was looking at your map showing the sort of location of the urgent care centres and the X-ray facilities and all the other bits and pieces around the area, and I can picture the population centres on there, because I know the county areas particularly well, and I know Charnwood in particular extraordinarily well. But visualising through heat maps or whatever the population centres and how they map to some of the urgent care centres particularly if we're talking about hyperlocal data, being able to actually say, you know, within 10 minutes somebody has access during these hours to this urgent care centre for this particular reason, or likewise, you know, pharmacies, likewise, then actually understanding, for instance, when you've got people turning up at LRI and you're saying, well, you know, actually your access point should have been the LPT, or it could have been a pharmacy first, or it could have been your urgent care centre, because actually we don't want people on the LRI site because we're busy enough already. Being able to actually hyperlocal dataize, link through to some of those campaigns, being able to actually say, you know, this particular area is turning up too much at LRI, when actually they've got facilities locally. That means that actually, as far as our campaigning is concerned, whether it's through the districts or elsewhere, is actually focused on that particular area. Is that something that's being done? Because it sounds as if it probably is needed from your perspective as much as anything else, but it sounds as if the data is actually available.
Yeah, it absolutely is. And we can drill down to that level. So we've got a particular area, it's not in the county, it's actually in the city, where we've drilled down to a very, very significant need that's driving a lot of our ED attendances, that we understand if we did something differently in that particular area, we could manage that. What's really difficult is, and this is not about blaming anybody here, but it's very hard as a patient to know what you need at that particular point in time until you've had a conversation with somebody, be that a receptionist or a clinical navigator or one of our services, because the range of offers is very nuanced according to your need. And so even within those hyperlocal areas, you've got different populations. So an elderly population and a childhood population need very different needs in very different places and have very different problems. So many of the additional services we've described here are for our frail populations, the full services, the community response services, virtual wards. They're often our older comorbid frail patients. So it's a very different offer. So as much as you can educate and do communications, there's something still about that point of entry into the system where you need to have somebody who's advising you on where to go, because it very much depends on the particular circumstances.
Thank you. Right. In that case, rather than actually hogging the Nikki, we've got a couple in the queue first, unless it's on this one particularly. Okay. In which case, I'm going to go to Fiona next, and then I'll come back to you, Nick.
Thanks, Chair. Just wondered, looking at some of the slides here, you talk about 50 to 80% of activities primary care type. Okay, but can you split that between county and city people? Is it more in the county, less in the county? About the same?
Yeah, so the data that's on that slide is city and county provision, because that's the information that I had to hand in terms of pulling this together. But yeah, we absolutely can drill down, and increasingly we will be doing more of that as we expand our neighbourhood health model, and we start really focusing down on the information that's available at a practice and a neighbourhood level will help us to do that more. But at the moment, I would say it's slightly higher in the city in terms of those people that are attending, and some of that is around geography, and some of that is around information that's available to people. So slightly higher in the city at the minute, but it's not massively different.
Okay, thank you. Can I keep going? Okay, thanks. One of the things Healthwatch is repeatedly told by patients is that they ring their particular surgery and they find it either takes quite a long time to get an answer or they don't, and people get impatient and hang up and do something different, like go to an urgent care centre instead of waiting. So I know there's been a lot of development around cloud telephony. Can you give the committee a sense of how that is working now, and whether it is actually taking patients back into primary care rather than out to urgent care? Thank you.
Yeah, so cloud-based telephony is a success story for us. Actually, we've got all of our practices covered by that now, and so for the vast majority of what that means is that you can be either called back, or your position can be managed on the queue, and you can be directed to the right service as well. So that's really, really helped. Online consulting is also helping with managing the telephone access issues, because it means that patients can do that whenever they want to. They don't have to do it at a particular point in the day, submit their online consultation and be contacted back from the practice. I think the other thing that's really important for us also is the trials of artificial intelligence that are occurring. So we've got 7 or 8 practices now, many of them actually in the county, that are looking at an artificial intelligence triage service to map patients with their problem directly into a slot without having to speak to anybody. So again, it can be done when they need to in real time. That's really important. What I'd also say is last calendar year, we had our record number of GP appointments. I mean, general practice appointments. That's all people that work in general practice. 7.4 million appointments across LLR. And again, 2/3 of those were in the county. So in terms of provision, in terms of actually capacity, we are really increasing that significantly. We're also a system, particularly in the county, we're doing very well with Pharmacy First and our referrals to Pharmacy First. So we have generated a lot more capacity in general practice through Pharmacy First. So cloud-based telephony, online consulting, increased capacity overall, and Pharmacy First have massively improved provision in general practice. It still remains difficult. And I think there's an expectation bit that we're talking about earlier on. It's still difficult for sometimes for some of our patients to get through when things have been difficult. We've also had collective action running in general practice nationally. That has just been paused, which is a really positive thing, but that has also been something that I think has affected access as well to our population.
Okay, thanks for that. Given the success of the cloud telephony and the other measures that you've mentioned, would Healthwatch be right in thinking that actually the trend of people dodging primary care and heading straight towards an urgent treatment centre or an urgent care centre is reducing then?
I think it's actually about the demand that we've got. We've just got rising demand and complexity. I mean, if I reflect back to the conversation we had at the last, I think it was joint task actually, talking about the UEC, the demand is rising inexorably actually, and the challenge that we've got is meeting that demand in a proportionate way. So some of it absolutely needs to be seen on the same day, but we can't completely change human behaviour. People want things today, and I think that was the point that Councillor Seaton made earlier on about actually there's a very high expectation to very fast response all the time. We know people have got busy working lives, busy family lives, and sometimes they want things when they want them. But actually, again, I'll go back to 45% of our patients can get an appointment in general practice within 24 hours. 85% can get an appointment within 2 weeks, which is usually appropriate. Again, we've got this extra provision in Pharmacy First as well. We've increased provision in our urgent treatment centres over the winter to manage that. So I'd like to think it would do that, but I think with an ageing population and rising public expectation, it's really hard to say that we will definitely achieve that. We're trying to make sure we get an appropriate value for money out of our urgent and emergency care services, because our urgent emergency care services are some of the most expensive part of our system. So we want to make sure we've got value for money there, and we've got the balance right with our mental health and our preventative services and our cancer services and everything else that we've got. So there's a balance between meeting all of that, trying to meet all of that demand, and using all our resource in one part of the system, which actually isn't the significant part of where healthcare is delivered.
One final point, if I may, Chair, thanks. Another issue which crops up repeatedly at Healthwatch is dentistry in the county. So I'm just wondering if you can give the committee a sense of how much activity is skipping the primary care element of dentistry and going straight to an urgent treatment or an urgent care centre.
I don't have the figures with me, but and again, I think we highlighted some of this in the previous meeting, that we have done some flexible commissioning this year with our dental contracts. So we've tried to target children and young people. We've tried to target some of our deprived populations, learning disability, to increase dental provision across LLR in general, not just county, but LLR in general. We've increased the payment for the units of dental activity to try and encourage more activity within dentistry. We've also had some golden hellos, if you like, some incentives to encourage people to take on new patients. It's a new patient premium, as it's called. So we've put a lot in this year. We've actually spent a lot more of our dental resources here to increase capacity. It's still a challenge, but we have made some early headway on those challenges in the county, but also across LLR.
Thank you very much for that. Fiona, you've even got a fourth question. No. You haven't got a fourth question.
I decided not to.
Okay, that's great. Thank you. And I do remember the stats on access, and there was particularly in relation to the aging population within the county, and I think the movement in the last 20 years, and it was using language probably carefully, but it was extraordinary, the impact of the aging population, and particularly the virtually doubling of the number of people over a certain age, and the reflection of that, particularly on access to emergency departments and what it meant for beds in particular. It's just, maybe we're not clear enough sometimes. Just where some of the major problems are occurring, and why. And perhaps making people actually understand that this is, unfortunately, this is not something you can just disappear overnight, because it is inherent within our demographics and will be for many years to come. Okay, Nick.
Yeah, thank you, Chair. It's just picking up on the point what Louise talks about, the tags on dustbins like that. You've got the ideal way of getting all that information out already. Everyone, I don't think there's many households in this country at some point doesn't have prescription. Well, these prescription bags, why can't you put the information onto those? So everyone's going out all the time with that latest information out to people. Well, I'm just trying to look for it on the NHS app, and I can't find it on there neither. There's no link to it. I spent 10 minutes. I think I've ordered 2 repeat prescriptions and ordered a doctor's appointment, but I couldn't find that signposting to tell me where I wanted to go if I've got a fractured finger or something. So I don't know if that's an idea what you could use.
So I'll pick up NHS app, and I'll let Jenny pick up the dustbins point, or sorry, prescriptions point. So NHS app, we are going to be seeing a lot of messaging coming through that. So it's been a national rollout, and we're doing quite well. We could do better actually with the number of patients that are downloading it and utilising it to access their results, their prescriptions, and book appointments. And we're going to also be able to, you're going to be able to book your secondary care appointments via that as well. So that's really, really positive. Well, what we will be seeing is a lot more messaging coming through that. So I think it speaks to your point absolutely in terms of how do we get those messages out to our population from a national perspective as well. So that's a really positive. I'll let Jenny answer the one about putting messages on prescriptions.
My mum's actually got the NHS app, which is actually an achievement, so it just reminded me. But the point in regards to prescriptions, I've worked in different systems, so we've used that before. But it actually comes at a cost, and that's the issue, is that it costs us money to be able to do it, and we've done all sorts over the years. We've done stickers on prescription bags, etc. I completely agree with you. We can use all those tools. It's thinking about how do we do it in the most cost-effective way, essentially, and how can we do it without it incurring costs, because unfortunately printing, etc., does actually involve a payment. But I take your point in regards to using the things that we've got available to us, and that's absolutely what we're trying to do. So without boring you senseless, where we have to use our skills and communication to see where we can get people to help us. So if we think about a lot of our local providers, businesses, etc., that work on the ground for us, I'll go right, football leaflets, etc., all those sorts of things. That's often where we get people willing to put something on those for us without a cost, and that's a lot of the work that we do regularly, is looking for those opportunities where we can think about where we can get those messages out which won't incur a cost, and that's what we spend a lot of our time and effort doing when we're planning and looking at those ways in which we can reach people, so it helps. So I am always open to anybody, and certainly everybody around this table contributing and giving us ideas of how we can do things. And I absolutely agree with you in the sense of it's quite frustrating, isn't it, when you can see a solution and we want to do things, and we're always looking at ways to do that in the most cost-effective way. I will come back to the fact that we have used some really good tools that we haven't done previously, which is in regards to using things on the ground. You'll see big screens that drive around, etc., on the side of buses, not buses, like vans. And what you can do with those is you can actually drive them to places and have the information on the side of them where you're going to get a huge amount of footfall. So, for example, like on the weekends, you get loads of you've got loads of people walking past. you can literally drive the van, so you're forcing people to look at it, and they're really clever because they've got cameras on top and they can see who's actually looking at it, so that's, you've got immediate evaluation through it. So we're trying all the things that you'll see, but like I've said to this room before, please share with us anything that you think that we're missing a trick on, and I'd really appreciate the free ones.
Okay, thank you very much. Final comment from Louise.
Yeah, thanks. Sorry for triggering that discussion. But I think this is where the ICS as a whole has got to start this slight move towards prevention. And if we're always going to say we haven't got costs because of the high end, we're never going to make the difference. So it is about looking at that and trying to move that to the left a bit, which I know the NHS are keen to do. So I understand about costs, but we've got to find a way somehow. And with electronic screens, you're relying on people to have the memory when there's an issue. And there are some people who aren't on the internet. So we have to make sure we include those. So yeah, I'm pleased we've had the discussion. More for you to think about, Jenny.
Thank you very much, Louise. Look, we're going to draw to an end on this particular paper. I mean, I think the point on this paper is always really to, from our perspective, you know, we represent the 720,000 people that live in the county area. It's really important, as far as our residents are concerned, that they feel they can actually access what's important to them from a health perspective at a local level as possible. And I suspect that's probably your hope as well. And whether it's Pharmacy First, whether it's through the LPT system, or whether it's through the urgent care centres or the urgent treatment centres, to keep people out of the ED is absolutely critical from the NHS perspective. And I think from our perspective, you know, it's important for our residents that we actually get that access as close to them as possible, ideally within a 15-20 minute drive, or even closer if it's walking and public transport. You know, getting to the city is not easy for a lot of people. It's fine if you've got your own car, but a lot of the people that are trying to access those services out of hours are trying to do so without access to car, or sometimes they're in a state that they can't actually drive in the first place. So they're reliant then on friends and family, or they're reliant on public transport, or reliant on trying to organise a taxi. And that's obviously not great for them as an individual. It's puts them under huge amounts of stress, but also it's not great for you because they are turning up at LRI. They are not local to where they live. So everything that you can do, whether it's through signposting, advertising, providing facilities close to where people live, is obviously a huge advantage for you as an organisations and for all your organisations, but also for our residents as well. So that's really, I think, the message for all of us from this particular item. I'll end on one final point. Your comment about accessing healthcare within 48 hours. I always like to be a secret shopper. Last week had recourse to try and get something sorted. Went to a pharmacy to start off with, Pharmacy First, which was it's a really good initiative. It wasn't something that they could actually deal with, so they signposted me back to the practice. As I walked out of the pharmacy, I went onto the NHS app. I actually managed to get an appointment the very same afternoon. Saw one of the acute nurses because that was the available appointment, and walked out of there within 6 hours of walking into the pharmacy, walked out of there within 6 hours with a prescription ready to be picked up from the pharmacy across the road from the medical practice. 6 hours, door to door. Couldn't have been easier. Used all the tools that I'd been signposted to. As a secret shopper, I have to say I was quite impressed. Really impressed. But you know, it proves it can actually work. So with the right messaging, hopefully you can get people to use it, and then they can also get access in the way that I was able to last week. So the system can work, it should work, and hopefully it will work. So thank you very much for your time, and thank you very much for joining us. Thank you. So now moving on to our final item of today, which is item 10, which is addressing social isolation and loneliness in Leicestershire. We have Fantastic. We've got all four. Brilliant. So we've got Fiona and Victoria who are going to help present. And we also have Simon and Anna who are part of our local area or LACs who are going to hopefully be able to give us a bit more information about what's actually done within our local area teams. So I'm going to ask in that case, Fiona, if you want to say any comments and draw any points to the paper. Thank you very much. As I mentioned earlier on, I have to say, really, really good paper. Really enjoyed reading it. Some great references in there, really well referenced and cited as far as the paper is concerned. Very high quality paper. So thank you very much. Over to you with that praise.
Thank you. So I will assume that the paper's already been read and just sort of highlight a couple of the key points. So just when we presented the work around the suicide prevention consultation around that strategy a few months back at the end of last year, the issue of loneliness and social isolation in relation to suicides was one of the things that came up. And as a result of that, we were asked to come back and talk further to Scrutiny around that, and particularly around how loneliness and social isolation is addressed in the county. So hence we're here today. So for the purposes of this paper, we're talking about loneliness and social isolation. Though as defined in the paper, we're talking about them kind of almost interchangeably at times, but obviously recognise there is a difference between the two, but they are obviously very closely connected. So in terms of background, there's a recognition, quite a wealth of evidence that loneliness adversely affects our health. And it doesn't just affect our mental health through things like depression, anxiety, and sometimes leading, sadly, to suicidal thoughts. It also actually contributes to our physical health as well. So it can impact, for example, on heart disease, strokes, and dementia. So it is quite an issue for our population. And we know that loneliness and social isolation affects many people in the county, and it can affect people at different stages. So we stereotypically might think of older people being socially isolated, but actually equally it can be an issue amongst younger people and indeed in young adults. In terms of what's in place locally, there is a huge amount in place within the county to address this agenda, and that ranges from work within Leicestershire County Council, so services and support provided by LCC. So I've mentioned public health is one of those that's focused on within this particular paper. So for example, the local area coordinator services, but also adult social care provide support in this area. The district councils, quite a considerable amount of services and support, voluntary community sector, the NHS, and the list really goes on. So I would say this is very much a snapshot of what we have available locally. There is a huge amount there. We focused on the prevention and sort of resilience end of the scale, so rather than more sort of specialist or acute elements. And we focus particularly around that public health element, and hence we've got Anna and Simon here to talk about the local area coordinator service that I know many of you will already be familiar with. So what we have in place ranges from loneliness toolkits, help and support in that way, to library services and support through there, community cafes, multiple VCS projects, and obviously local area coordinators. There's quite a lot and quite a range of different types of support and help. So in conclusion, it's an issue for county that is very well recognised. There is much in place to address it, but we and other partners continue to build what is already in place. So obviously we're happy to take any questions, but particularly we've got Simon and Anna here to help with any queries around the local area coordinator service.
Right, thank you very much. I'm going to go to Bessie first because this paper really came out of, and then I'll go to Mike afterwards.
I used to do a lot of work back in Belfast, visiting, some of the troubled communities. And one of the issues that it was an old gentleman in particular, and he said to me, he suffered from the most common disease in the world. And I says, what is it, Jim? And he says, loneliness. I probably told you before, but it really hit me and it's never left me. And there are a lot of individual, especially nowadays with so many single households, there's a lot of people out there and they don't know how to reach out to ask for help. They find it really, they struggle really even to go to local community centres. And I've often thought maybe even using Leicestershire Matters a bit more and saying, if this is, these are the places you can go. If you've got issues, this is who you can reach out to. So I just want to know what more we can do as councillors and the council to actually help people who are in that situation who really don't know where to go to help for help.
Thank you. I suppose it'd be really good that we probably strengthen our connections with members in terms of utilising the loneliness toolkit and communications that have been developed and is already in the public domain. Because you will be probably aware of individual residents that probably may be experiencing loneliness.
Yes.
It doesn't always present itself in a very obvious way. It can often be a secondary issue that kind of is identified to our operational teams or a tertiary issue. So to make sure that the toolkit and the communications that support that toolkit is available to you as members, I think is something that we can strengthen.
Thank you, Chair. That would be very helpful. Thank you.
Thank you very much.
On that basis, then, it very quickly to chip in, since we're in the 1st of May elections, an initiative immediately afterwards through our democratic services would be ideal.
Okay, Ewan, you can take that back, I'm sure. Thank you. Thank you very much, Trevor. Mike.
Not that I pretend to know a great deal about these issues, but I come at it from a slightly different perspective than Betty. I think there is a great deal of stuff out there that people can tap into, either free or sometimes paid activities, not just through the councils, but lots of other organisations do a lot of stuff across the board. What I can't get a grasp of, these people, whether they're young, old, middle-aged, who are lonely, a lot of them know it's out there, but won't make the move. Why? What can we possibly do to get them out of the armchair doing something that will make their physical and mental health probably better? I mean, if you've been in work all your life, you've built a group of people around you, you know people, you know friends, or have an extended family. It's probably not an issue, but as Betty says, a lot of people live by themselves now, either in flats, apartments, houses, and they get into a way of life that becomes a rut, and they don't go out and meet people and see people and do things. How do you change that?
And I think that's supposed to come onto that as having experience of working with people in communities. I think often verbalising that we're lonely is one of the hardest things to say sometimes. And we've got countless examples, I suppose, where after we've worked with people, they've been able to identify that they were lonely, but they found it very difficult to say at the time. I also think that actually a lot of the activities that we have around loneliness and isolation, we underestimate the bravery it takes to walk through a door sometimes. And I often reflect back on my own experience of starting as a local area coordinator and working in a community that I hadn't worked in, and going to the coffee mornings and nobody saying hello to me. And I remember thinking, if that happened to me outside of a professional capacity, I would find it quite difficult to go back. And I think a lot of people, when you get into the nitty-gritty of that, they all have experiences like that. So I think a lot of the work we try and do is to unpick that and trying to make those experiences positive for people. And when they've identified something that they want to work on, looking at ways that we can make sure that that first step they take is as meaningful as possible. But it is quite tricky, yeah.
The point was making that first step. You're talking about people you've managed to engage with. I'm talking about those people who haven't engaged with anybody and have probably little intention to do so. How do we get to them? I mean, they see bits of paper, they might see things on the television, local news, whatever, but nothing changes. How do you deal with that?
I think our approach for that is part of us being based in a community, and I think time and continuing to engage and continuing to be part of that community as much as you're there to help people. And I think hopefully in doing that we do see the people, or people are made known to us where taking that first step might be a challenge to them. And I think then it's looking at the tools and ways we've got to engage with people to try and encourage that. And sometimes that may take several months of spending time with people. But I think being present, being visible, trying to engage with people in a variety of methods is not a foolproof way, but I think it's one of the best tools that we've got to be able to try and engage people.
Right, next on the list is Nick.
Thank you, Chair. I'm actually the opposite of you two here, because I've got, well, did have two very good lads that were part-time, and I started working with my lads during COVID when I set up and run a food hub in the village. It's called a food hub because it's not like a food bank, and actually working with that and getting out to a lot of these people. And I'm looking, I've got Lauren and we did have Zara, who's not here anymore. And they were actually very good at communicating with people. A lot of people during COVID who didn't want to go out and everything else, but still needed help. And they actually managed to pick up on that with the volunteers we had at one point, pick up on that. Then the Lactors took that over time. But also setting up a group for elderly people who come together. She comes every month she comes and visits that group. And that's how she finds out other people, because one might say, oh, I've not seen such and such for weeks, she's not been out his house. And that's how another way of getting in touch with them. I think certainly the Lactors in my area are absolutely brilliant. I can't fault them at all.
It's a very good session, isn't it? Thank you very much for that, Nick. That's really good. Good, great to get that sort of feedback. Fiona.
Thanks, Chair. Healthwatch has been involved in a considerable amount of work around loneliness, together with Voluntary Action Leicester. And of course, the voluntary and community sector do an inordinate amount of projects tackling loneliness specifically, and also broader projects which have an impact of promoting less loneliness, for want of a better phrase. But it would be very interesting to understand what actually is the extent of loneliness in the county. You know, is there a measure you can use to actually put your finger in the air and say, well, actually, it's a really major problem we have in the county, and the trend is that that problem is increasing, or actually it's getting better because there's a pile of people doing a shed load of work. And have we been able to identify any specific communities or areas? I remember at a previous HOSC, one of the members really highlighted the farming community, for example. So do we have an inside knowledge of what sort of communities are impacted? And it'd be quite interesting. From a Healthwatch perspective, for example, we've done some inside reports into people living into temporary accommodation, and a big factor for them is loneliness, as it is for the asylum seekers that we've done an insight report on. The asylum seekers have had the benefit of the bridge coming in to help, and that has alleviated some of those issues for them. But it's obviously there's a lot can be done in all sorts of communities. So the basic questions are, what's the extent, and have we identified any particular communities? Thanks.
I'll pick up the first part of that, but I'm sure colleagues will be able to help. So it's, from my perspective, it's more difficult to really pin it down exactly, because obviously it's quite a hidden problem in many ways. I mean, if you look at fingertips for Leicestershire, the loneliness is something like 6% from the top of my head. And then some of the key groups that it sort of flags up is people in contact with adult social care services. It's fairly high. I'm going to say it's over 40% of those people were saying that they didn't have not necessarily so much around loneliness, but they don't have they feel social isolated. They don't have the social support that ideally, or the social relationships that they'd like to have. And the other one that really flagged up fairly high when you look at fingertips information is that I think something like 26% of people who are carers in Leicestershire feel that they have adequate social supports, and who actually feel that they are quite, susceptible to loneliness, which I suppose sort of fits with what you might think in the county. So they were the harder figures that I was able to find, but I'm guessing that some of my colleagues will have more.
Prior to COVID, there was a piece of work undertaken by Leicester University, and we were a major contributor to that study, which looked at the prevalence of loneliness within Leicestershire and its health impacts, but also the cohort of individuals that were most likely to be impacted by loneliness. Obviously, COVID happened quite quickly afterwards, so in terms of lots of individuals may have identified as being lonely due to social isolation, shielding, etc. But so we do want to revisit that, as that was quite an in-depth academic study which took quite some resourcing and also a significant amount of time. But we will want to work potentially with academic partners in the future to look at that, and we do link in with Val and other agencies in terms of gaining data to look at how do we use all of the data, both in terms of what services individuals access, whether that be adult social care services, whether it be a coffee morning, a community group, to look at if that can inform the way that we work in the future.
Thanks for that. Just one more thing. I see the toolkit was produced quite a while ago. What sort of plans do you have for updating it going forward? Thanks.
Yeah, so it's out, it's being reviewed at the moment, and then the changes were made accordingly. Just to say, we do want to do that across the authority and also its partners, so it isn't something that we want to do in isolation ourselves. So we want to hear the feedback from VCS organisations as well as our borough districts and community teams to see, is the toolkit still fit for purpose? Does it still work? Is there some things that have changed? Is it as accessible as it needs to be? Is it in the right format? So Anna's leading that piece of work across the authority at the moment.
Thank you very much for that. So I'm going to come in with the final question, if that's okay. So I look, I mean, Nick made an excellent comment about the lacks that operate across the county area, and I have to say, I think all of us as county councillors, our experience dealing with the local area team has been brilliant and really worthwhile. Also very aware of the scope of responsibilities that teams operate under, loneliness being probably one cohort of many others that you try and identify and tackle and support. And I think one of the comments that I'd ask really, which is actually about signposting, because obviously from your perspective is understanding the full breadth of access that people is available to them, but actually being able to give them signposting towards it in the most effective way that you can is really important, both from your perspective, but also from theirs. And I was just going to ask, particularly on the point of loneliness, what signposting is available? What tools do you actually use? I know there's an app which is referenced, which we did try and research. I think we found a website, the llrjoy.com, which seems to be a national thing that you then actually put your postcode in. I think it was probably what Ross found, but whether there's actually something that's actually a bit more localized where people can instantly go into it. Who wants to answer?
I'll start, and I'll probably ask Anna to chip in. You're right. The Joy app is, I think it's an ICB funded app, which is a social prescribing application. So individuals, teams, and individuals can use that app to look at what's happening in the community locally. So if an individual probably is experiencing loneliness or isolation and they want to connect something in a geographical area or around special interest or around faith as an example, they can use that as an app to filter, so that happens on a Tuesday and it's free, or there's a low cost to that. That does rely on an amount of digital skills. The local area coordinators also have asset mapped their areas, and because they are based in their communities nearly 100% of their time, they're fully aware of what's happening and what's changed. So again, they kind of hold that both from various systems, but also in their own mind too. So when they're having them conversations with individuals, they can connect them into to that offer as well. And just to take a previous point, that first step is often the hardest, and local area coordination often identifies of walking alongside somebody, so they might want to walk through that door with that person for the first time, but they also want to work with that group to ensure that it's inclusive and it's supportive for when that person does arrive. The other signposting, obviously within public health, you also have First Contact Plus, which is a professional, signposting service. So again, they have the identified pathways available, so local area coordinators can use that, and any other professionals too. They can have that really good triage and holistic conversation and be connected to the right team, I suppose, through one conversation, and those pathways are really well established. And have I missed anything?
I don't think so. Like I said, that local knowledge I think is really key, and I think also the way that signposting happens, we try and make it as meaningful for people as possible. I suppose there's an acknowledgement that if I just gave someone a leaflet, the chance of them taking that leaflet and then attending that coffee morning is probably quite slim. So I think it's understanding the person that we're having the conversation with, understanding how best to share information and the conversation that goes alongside that, just to make sure that they feel as well armed as possible. And I think there's a difference between the stuff that we've got available locally and some of the more county-wide offers, and I think then it's discussing the options that we've got with people and helping them figure out what the best step for them is, and also supporting them to be able to take those steps themselves, because we know change is more meaningful and more likely to happen if you're in control of that. And I think then what we do as a team is an awful lot of checking on our knowledge, sharing information, inviting people in so that the team are as well armed with knowledge as they can about different offers and support services that are out there and how we can work with them.
Fiona, do you want to any final comments?
Yeah, I was just going to say, just in addition to that, there are obviously a lot of the other partner organisations do a lot of that sort of signposting and navigation as well. So I was thinking of social prescribers, mental health neighbourhood leads that we have in all of the districts now do an awful lot around sort of putting out there what services and support is available. So just to sort of recognise that that's in place as well.
I think just adding into that, within public health, we have a bit of a no wrong front door. So however people come into us at the department, we're all well versed in each other's ways of working, and we make sure then that resident gets to where they need to be, so that we're not saying, no, it's not me that you need to speak to.
That's brilliant understanding. So look, I mean, it's the work that's being done is phenomenal. It's a great network. It was great, for instance, in the paper to actually see its origins. The Western link to Western Australia, which was fascinating. Having worked with the coordinators for a long time, to finally actually work out where this great idea came from was brilliant. So really well put together paper. Some great references in there. Really good to see the work you're doing. Particularly, I know this is the subject area that Betty referenced at the beginning, but it is important, and it's not just one cohort or one age group or demographic that is affected by loneliness. It really is something that if we can give people the right access routes to the right organisations, then hopefully it can change their lives in a way that makes it really important for us as an organisation.
Going to say on that note as well, obviously we've got a wealth of stories. We've not gone into too much detail about that, but if anybody wants to know more, or you want me to present examples of where we've tackled loneliness or where loneliness has been a theme, then do let me know and I can share those.
Thank you very much, Anna. Look, Anna, particularly thank you and Simon as well for coming along today. We'd all echo Nick's comments from earlier on. It's a great network, great group of individuals who really have got to know their communities in a way that probably nobody else does. So thank you very much. Thank you also, Victoria and Fiona, for joining us today as well. Really good to end on a really good success story, and hopefully a huge amount of work to do. So look, thank you very much indeed. We're now on to the sort of tail end of the meeting, really. So item 11, work programme to note for the joint HOSC. You can see the reference in there. The last meeting of the joint HOSC actually takes place next week, and then Ewan is relieved and it goes back to the city. So the work programme will continue through the city. Item 12, next meeting is going to be on the 4th of June. As Trevor quite rightly pointed out earlier on, there is a small thing called an election on the 1st of May. There are a number of us who are retiring from the County Council, myself included. Who else? Trevor, Anyone else? Ross, Louise, Betty? You never know. You never know. You never know. Look, can I just say, for those who are retiring, I mentioned to you at the beginning of the meeting, it was 32 years ago that I actually stood to be a county councillor the very first time, not in Leicestershire, I have to say, in Suffolk, but where I was then living. But you know, it is an amazing experience. Your comment, Mike, about loneliness. The one thing you never feel is loneliness when you're a county councillor or any representative at all. I'd like to pay particular thanks to Louise, who obviously has sat here being the lead member, certainly for the last duration that I've had the pleasure of being Scrutiny Chair. Louise, it's been really good for you to be our lead member. I think you've always been open to any discussions that any member around this table has brought to you, and we really welcome that. So thank you very much. Thank you to all of the committee members, particularly those who are stepping down. Your shoulders can finally rise up as the weight of lifts from them, but hopefully you'll leave this place feeling as if you've been able to make a bit of a difference in whatever area or field that you've chosen. Well, thank you very much, Mike. That's very kind of you. It has been a pleasure, and I've been very blessed to have a really good, interesting committee. And we've always had the benefit of Ross's emergency support if ever our teeth are hurting. So thank you very much, Ross, for that. I'd also like to pay thanks to Ewan as well, who's clerked this meeting elegantly and efficiently, and has always prompted me whenever I've made a complete error on something, which has often taken place. But Ewan, thank you very much. May your next committee be less stressful than this one. Hopefully, the next committee chair, whoever that may be, will be as grateful for your support as I have been. So with that, to all of you, thank you very much. And for those who are putting themselves up again, good luck, even if it's a surprise, Mike. Okay, thank you very much. Meeting closed.